CCG governing body. Apologies from absence. I've only had apologies from Frida for this meeting. Any new declarations of interest or declarations of interest pertaining to anything on the agenda, please? Okay, somebody's shredding something. Perfect. So if we could go to the minutes, so again, just for my convenience more than anything else, I'm just going to take them as read and give everyone just a moment to comment if there's issues with accuracy. Somebody's got a motor running somewhere in the distance, so I don't know if it's just me that can hear that, but it might get a bit frustrating if that happens every time. Okay, so I will take those minutes as an accurate reflection of the last meeting. Thank you. Matters arising, so we've got two. Richard, that's on the agenda. Actually, is Richard with us? I haven't heard from him.
Yeah, it's on the agenda perfect. Later.
Amanda, did you want to just quickly give us an update on where we are in terms of getting team members to board?
Yeah, thank you very much, Chair. So I failed miserably for this particular meeting given other pressures of work, but I will endeavour to action that for our March governing body. And that will be in the context of getting other team members present at HEB to correspond with an appropriate agenda item.
Perfect.
Thank you.
And Lisa, I'll let you update us about the mortality rate when we get to the quality item, if that's okay. In which case, let's move on to the Chief Exec's update. Ed?
Thank you, Chair. And just two updates from me and two kind of areas of work where we've been putting in some superhuman effort, both everyone on the board, but everyone in our North East Essex Alliance system. So firstly, as we know, the new variant of COVID was dropped like a pebble into the Medway and spread up into Essex over Christmas and into January, creating huge pressure on our health and care services, particularly in the south of Essex. But we've felt it very much too here in North East Essex, and we've seen very high COVID rates, particularly in tendering. So there's been a huge effort to keep our services safe and open and to manage that wave of demand, and we've done it very effectively, and I think it's a great testament to all the collaboration and relationships and indeed the strong leaders that we've got in the system that we're able to navigate this particular storm. So thank you very much on that in terms of how we're managing COVID pressures. And secondly, a massive amount of work, a mammoth amount of work has been put into the vaccination programme to keep people safe and protect our communities, which we're all absolutely committed to do. And whilst we had a slower start than some systems, we've accelerated very quickly in the past fortnight. And as of this morning, we were, as a system, over 90% of our over 80s have received their first dose, which compares very favourably to many systems up and down the country. So we will continue that rate of progress going forward. We've got a commitment nationally. Everyone has to deliver their commitments around the first 4 cohorts, which is the over 80s, the health and social care staff, frontline staff, our over 75s and our over 70s, and our clinically extremely vulnerable population. So a lot of work still to do over the next fortnight to meet that commitment, but I know there's a collective resolve and determination to do so. So thank you to everyone on this board for your leadership, and more importantly, thank you for our community who have been fabulous. They've been patient. They've worked with us, and it's been absolutely a team effort. So that was my update. Thank you, Chair.
Thanks, Ed. And can I also echo your comments, just really to thank everyone. I think the CCG team particularly have been amazing in terms of just realigning themselves with different roles, down to even being couriers to ferry vaccines from one place to the other. I think it's been fantastic. And as a GP practicing, it's been nothing short of amazing to see people through the parish council come and help us out at the practice in the pouring rain, I might add, directing people in and out through the surgery and directing traffic. It's just been really inspiring to see everyone come together, and I've never seen it like this before, with everyone in the community playing their role, and everyone is so grateful. It's just fantastic to see in our local area. Pam, sorry, you got your hand up. Sorry, I didn't see.
Yeah, I wonder whether we can make special applaudit for GPPC and the support they have given the system here in North East Essex, and particularly Jo Sunderland as their Chief Operating Officer. I think she's gone above and beyond the call of duty to support our practices that we had in the delivery model, operationally managing a lot of the sites. And I think without her, we'd have been unstuck quite a while ago. I think in recognition of the CCG staff, I think Lisa, your team and others that have trained as vaccinators and gone out and supported vaccinating, has given us great resilience within the care home sector as well. So thanks specifically to all the registered nurses and AHPs that have gone out vaccinating.
Thanks, Pam. I agree. Mark, sorry.
Thank you, Hassan, and thank you, Ed, for that report, and for the people that Pam has just praised as well. I think it's really, really positive news. I'm sure it's over 91% now, by the way that you recall things, and the fact we've got the mass vaccine rollout happening at the stadium, so I'm sure you've gone even beyond that as well. So that's fantastic to see, and we don't see enough of what goes on behind the people that Pam has just referred to, the people who are upskilling and reskilling and getting out into the community. So thank you to them. I know there were concerns at the beginning, and we expressed some of our experience as local members from the council as well. So thank you. I appreciate the briefings that Ed, Pam, Simon and others have given, and Nick Hume from the hospital as well, because informing community champions to then go and explain and reassure the public is the way to do it. I know there has been raised expectation with the vaccine rollout, and it has taken time to get it right. Some of the practices across the patch have not been as consistent. I appreciate that. But actually, one of the explanations, Pam, you gave to me before is the sustainability of these mass vaccine sites, so that actually GPs, our local GP practices, can get back to doing the business as usual care and support for their local communities. So I appreciate everything that's been done so far and the sustainable solutions that will see us hitting the targets very soon. Thank you.
Thank you, Mark. Myrna, welcome.
Yes, I know how hard you've all worked, and everybody's worked, and we all need to be very grateful. But it just seemed that I had so many complaints here in Tendring about a very slow start, and even now we're very limited where we can actually go and get the vaccine in Tendring. Not everybody here drives or has cars, and it's quite difficult for some people to be able to travel. And it's just, I don't know what I've been saying to people really. I've been trying to reassure people, but there definitely has been a feeling that we were a bit forgotten in Tendring, and whether that's the council or whatever it is, I don't know, but we were forgotten.
Thanks, man. I'll let Pam come in. I mean, so from my point of view, you weren't forgotten. I think I probably do agree. We had a bit of a slow start coming into this because there was just a little bit of uncertainty as to where and how. And there are obviously some logistical challenges, weren't there, around being able to store the Pfizer vaccine when it first came out. And one of the reasons why we're able to now expand and be more adaptable is because the new vaccine, the AstraZeneca vaccine, allows it to be transported far easier. So it means those centres that are further, that don't have to think about special freezers and special fridges, can have more access to the vaccine. And as the weeks roll on, even this week, you should see hopefully a change in that, because we're getting more and more, or some more and more deliveries of the vaccine that we can mobilize. And that means hopefully more and more practices and more local branches will be able to come online to try and address those people that you've mentioned that can't travel. So we are all learning as we go, and I know, you know, as I said, I think it is fair to say we had a bit of a slow start, but we're gaining momentum and actually overtaking some now. Pam, did you want to just give Mona a bit more reassurance?
Yeah, absolutely. So we've taken a hub and spoke model. So the hubs do the Pfizer, because actually we can't travel that, as Hassan has said, but our spokes are reaching out to Frinton over the weekend, Walton, in tendering these areas are. So we've got more and more practices that are offering us support. Brightlingsea's done a clinic this weekend, Mersey. So there's a significant amount of reach out into our population now, and that model we will be making sure is more consistent going forward. But also we've got the roving model, so with the CCG staff and practices going into those that are housebound. So Myrna, if you can tell me where your complaints are coming from, what area, I'll give you some assurance as to what's coming on around support in those hubs.
Thanks. Pam?
I agree with you. It is getting better. It is better, you know, okay. But there was just a very slow start, and people felt as though that they were forgotten a bit.
I think there was a little bit of a mismatch, if I'm myself, between national comms and what we were able to do locally as well, and I think that's fair to say. So there's an expectation, isn't there, that people feel that something is happening when it's coming out nationally, but actually on the ground it doesn't always translate like that. So, but as Pam said, you know, that the supplies are coming. And just as a point of reference, I know our practice isn't in tendering, but you know, from using the hub to being able to get our own vaccine in the last 8 days, I think we've done something like 1,400 vaccines, and so, you know, we've gone from being 11th as a practice in the area in terms of the number of people we've vaccinated in the area to 6th in just a week. So, you know, there is a more of a rollout is happening, and all staff are just desperate and itching to get involved and help out with this. So as the vaccine rolls out more and more, we should get more of that. Pam, you've got your hand up. Was that for something else? Just while you're on mute? No, that was that. Okay. Max. Are you on mute, Max?
Thanks, Chairman. Yeah, I'm just unmuting myself. It just takes a few seconds. My slow hands. Yeah, no, just a couple of questions. Well, a question and a comment. Ed, do you have any sort of messaging centrally about the second vaccine? Because that's quite a common question you get, particularly with Pfizer, because some people are quite gemmed up on the evidence, really. And the lack of evidence around delaying the Pfizer vaccine for 12 weeks. Are you getting any messaging or any clues as to when the second vaccine will be available? You know, the second dose of the vaccine, I mean. That's my question. And also, just a comment about tendering. I can see Myrna's. I think the difference with, plus the slight difference with the tendering centre is around parking as well. Parking in the centre of Clacton is not easy for people, so getting to whereas at the primary care centre at least you can park, and it's free. I'm not sure whether it's free in tendering. I don't think it is. So that might be something that, you know, is an issue with the tendering systems. Yeah.
Okay. Yeah. Thanks, Max. Ed, did you want to hazard a start?
Yes, just on the car parking issue, I saw a note yesterday that I think the NCP car park is going to be free opposite the centre in Clacton, so that's really helpful if that's the case. So really good news. Pam may know more than me on that. On the 12 weeks second dose, I think that's still the national line. There are a lot of questions coming through about immunity and whether 12 weeks is right and all of those questions. But at the moment, I'm not aware of any deviation from the plan. I think the part of the issue is once we start getting into those second doses, plus we're being pushed to get through the next cohorts, that's a huge amount of work that's going to build up at the same time, isn't it? So there's something about how we forward plan for that, because we know it's coming. But sorry, I can't give you a more the answer that you may be looking for, Max.
Okay.
Thanks, Ed. Thanks, Max. I mean, the expectation at the moment, so what we're told through NHS England, Max, is that they will schedule the second vaccine for 11 weeks. And by scheduling at 11 weeks, it means you get your second dose within the 12-week criteria. So they are still, we are still aiming for a 12-week second dose jab, but to be given at week 11. Pam, you got your hand up? Sorry, is it to come back on that before we move on?
Yeah, just that we've been told now that we can book from the middle of March, so at that 11-week point. So we will start to work through the booking process. And on the car parking, so the car parking isn't exactly free. It's so at Clacton, the car park, we've got a deal with NCP Parking, such that if anybody's unable to pay, if they go over the time that they've spent in the car park because of the vaccinating process, we take everybody's registration number and then we submit that to NCP and we pay a reduced charge for their parking. So we're picking up the parking as opposed to it being free as such. And it may be semantics, but it's just to be clear. Car parking is probably one of the most complex arrangements, second to health, I think, I've ever been involved in. So it's not just somebody that owns a car park that you can go and have a conversation with. People administer the tickets, different company watches it, somebody else owns the land, and then NCP have their badge on it. So it's been quite an ordeal to get ourselves arranged in this way. But if there has been any fines issued to anybody, we have got a process where we can get those cancelled with NCP. And if anybody comes to anybody or anybody watching this this recording has an issue with car parking fines from Jackson Road associated with the vaccine, then please contact us and we will make sure that it's dealt with. So it has cameras on the car park. So if somebody doesn't give us their registration number, it's actually impossible for us to submit that registration number to be whitelisted, as it's referred. And we did have a slight gap in the administrative process when there was a change of leadership at the centre. But we've got a slick process in place now, so there shouldn't be an issue. But I'm happy to deal with any of those issues that come through. We've got a process to deal with them, and we have an agreement now with NCP car parking.
Thanks, Pam. So anyone that gets a penalty, do they contact the site lead?
Yeah, they can go to the site lead, or they can literally make me aware of it.
You can't receive emails from hundreds of people. So could we perhaps publish somewhere an email address where they could submit?
Yeah, they can come into PALS, and I'll make sure that it's dealt with.
Okay, let's do that. Thank you. Jerry, thank you for being patient.
Yeah, thank you. Myrna will know that the Columbine Centre at Walton's potentially going to be a vaccination centre, and we're expecting activity to start in January, and it didn't initially. But what you realise is that it's incredibly complex to set up a centre like that. We must have had 20 or 30 people to the Columbine Centre from the NHS looking at different aspects. But in the last sort of 48 hours, 2 or 3 days, we've had a tremendous amount of activity from the NHS to try and set this up as a centre. And as I say, it does make you realise how complex it is to do this all over the country. And I've got a lot of respect for the people who are doing it all, because it can be quite chaotic. For example, we've been dealing today with BT Openreach, and anybody who tries to deal with BT, we must have had about 6 or 7 people asking the same questions, asking for floor plans, wanting to turn up. And because the centre's shut at the moment to our usual activities due to lockdown, we have to arrange people to go and meet people. And of course, BT don't take any notice of that. They just turn up and expect to be let in. So I had to get the caretaker out of the bath on Sunday to go and let somebody in. He was actually in the bath when I rang him. So it is happening, and you know, it will happen. And I think once a centre like that, which has got free parking, is set up, then you know, there'll be much more facilities for local people. But I think we've just got to be patient because of all the efforts that are going in across the country to set up centres like that.
Thanks, Jerry. I agree. I mean, it's incredibly complicated trying to get anything like that off the ground, and even when you get beyond that, then you start to have the challenges of vaccine supply versus staff versus process for getting people in and out. So it all gets really confusing. And as you say, having to do that within the space of a matter of weeks across the country is no easy challenge. Ed, sorry.
Yeah, I was just going to underscore that point. The way I've heard it described is that you're essentially creating a new organisation from scratch. So setting up any of these sites, it's not just the staffing, it's everything. And it has to be absolutely right for our public. So that's why it's not as quick as people might assume it is. But in the long run, once we've got the sites up and going, that will really see us through to the autumn. So it's important we get it right.
Okay. Thank you all. Just going to check there's a comment. Fine. So no one else has got their hand up, in which case I'll just repeat my earlier statement, which is thank you, Ed, for all that you're doing to help lead us through and make sure that we're getting some vaccine locally. And thank you to everyone out there who's jabbing. I think, you know, without everyone jabbing, and that means the people actually giving the jab to the people at the front door, to the people directing traffic, you know, everyone is playing a part here. And that's the only way we're going to get out of this. So let's move on. So it's over to you, Myrna, for the Health Forum Committee report.
Thank you. Well, most of it, I was going to say take as read, but we are working very differently at the moment because we've lost some of our admin support, and that makes it very difficult for us to run. But we're doing the best we can. We're still having our meetings. We've got one tomorrow, and our committee meetings. And the only public meetings that we're still having is the PPG ones, and that's good really, because you know, they are the people that we would particularly want to engage with sometimes, because they know what's going on in their surgeries and the feeling of local people. So next week we've got another PPG. We're doing the best we can really. We're still trying to keep as active and letting people know we're there, but it's not easy when we've got hardly any admin support, but we're trying, very trying. Take any questions?
Max, you got your hand up.
Hi, Mona. I'm just wondering, what do you think about the possibility of getting some patient representation on some of the ICS boards? I mean, I'm chairing the cardiovascular one, and I think it'd be really great to have a patient voice there. You know, patients have gone through the system, cardiovascular system, you know, and also, I think the other thing that we're sort of talking about in the CRG is how we can promote more self-care in the community, you know, and obviously there's been a big transformation now in terms of the way the health service is working over the last year, and I think, you know, the general view is that actually we probably need patients to be more gemmed up on self-care, you know, this sort of concept of knowing your numbers, particularly from a cardiovascular point. What's your cholesterol, what's your blood pressure, what's your HbA1c, and actually how we can get patients more engaged in that, you know, than they possibly have been in the past.
I quite agree. Can I just answer that? I quite agree. I think that is something we could be more interested in. You know, often the trouble is we don't get the information along with it. You know, somebody says, "Oh, you ought to be doing this," and that, without really giving you the information of where maybe you can buy the equipment. I've had personal experience of this, and yes, I'm sure we would all like, and we are definitely, as patients, I feel, taking more responsibility for our own health, and that's a good thing.
Yeah, well, thanks, man. Can I maybe leave you to come back to Max after the meeting, perhaps, if you see how you can maybe facilitate that in terms of getting a
Yeah.
representative? Perfect. Lisa.
I was just going to offer a bit of a solution to that as well. So now we have Sophie Martin, who is the patient experience and involvement lead across the 3 CCGs. Unfortunately, she started during COVID and remote working, so it's been difficult for her to get to meet everybody. But I'm sure, Max, she would like to speak to you and maybe support you, Myrna, in that request around making sure that we've got patients in all decision-making areas.
There you go. We've opened the floodgates. I think, to be fair, one thing that things like Zoom and Teams now opens up is the possibility for people to be more inclusive, or for groups like that to be more inclusive, so you don't have to travel to get somewhere.
Just a quick comeback, Preston. So just to say to Myrna, we can tell patients exactly what blood pressure machines they should be buying. They're all about £20. And we're actually trying to. We are actually getting blood pressure machines out into the community, but there's going to be nowhere near enough to cover the population of people that need it. So, but that sort of information we can definitely get out to patients now.
Thanks, Max. Myrna, you put your hand up. Was that from before? You're on mute as well, man. Oh, okay. So if there's no other questions, perfect. So we'll note the report. Thank you, Myrna. Lisa, you're going to give us a.
Well, I'm not
update.
entirely sure there's much more to talk about, Hassan. We've obviously talked quite a lot about the vaccination programme, and when we come on to the performance report, I'm sure we'll give an update on how the organisations are managing.
Ed stole your thunder, basically, didn't he?
He did, really. I didn't like to say anything, but
right. But you're not off the hook though, because you've got the Ockenden report.
Yes, sure. So this paper just gives an overview to the CCG of the steps that we're taking as a local maternity services board and our providers in the first report that's come from Ockenden's review of maternity services at Shrewsbury and Telford Trust. So this is the first report. The investigation team have looked at 250 cases and felt that there were some immediate and essential actions that needed to be put into place. So wrote this first report. The 7 themes are in section 3 of the report and are immediate and essential actions that both need to happen at system level and at provider level. And section 4 details where we are as a system. So there is some work for us to do. We were already working as an LMS on our quality surveillance oversight of patient safety in maternity providers, but there is some work that we need to do, making sure that we have consistent twice daily ward rounds, consultant-led ward rounds in all our providers is an area where our providers are looking at consultant job plans. And we have got one amber on the Saving Babies Lives bundle, which is amber just because we're waiting for the pathway to be signed off by the clinical network, but basically it's in the fetal growth area, and our Ipswich Hospital Trust have actually put in a better service than they believe is recommended as part of the Saving Babies Lives bundle, in that there are more growths. They've put in an additional growth scan, but because it deviates from the bundle pathway, we have to get it signed off by the clinical network, which is why we have at the moment marked it as amber. So the timeframes for these 7 themes are that a detailed report needs to be submitted to the LMS and NHSEI on the 15th of February, and we have to upload the evidence to the portal in March. There will then be sites to triangulate the evidence that has been submitted. So we're just working to that time frame, and then obviously awaiting subsequent Ockenden reports. But thank you. I'll take any questions.
Thanks, Lisa. Has anyone got questions? Jerry.
Yeah, on the table about immediate and essential actions, I might have missed this, but who is the LMS chair? And because it says they should be a member of this board. And how do they report? Is it you, Lisa?
That is me, Jerry. Yes,
oh, right,
that's
okay.
me. So we're all okay on that front.
Thank you.
Thanks, Jerry. Can I just ask, Lisa? So, as I understand it, I think the community delivery units have ground to a halt, haven't they, as a result of COVID?
Yeah.
Is there? What are our plans for trying to bring that back online, and how does that feature in these plans? Because I know these were quite hospital focused, weren't they?
Yeah, so at the moment they are red areas, and we're constantly reviewing that, because although we do have midwifery-led areas within the inpatient facilities, we do know that the actually midwifery-led births numbers has decreased since they go into the hospital, and then a friendly consultant's doing a ward round, and before you know it, they're under consultant-led care and not midwifery-led care. So we're really keen, as soon as we can, to go back to the midwifery-led units, but it's all dependent on our response to COVID and when we can reopen them.
Okay, thank you. Jerry, put your hand up again. Was that an old hand, a legacy hand? Okay. Any other questions, comments? Okay, so we're asked to confirm our assurance of the LMS plan and governance. So we'll take that as assured. Thank you. So Richard, thank you.
Thanks, Chair. I've got a couple of colleagues who have joined us for this item from our public health team within Essex. So we've got Melanie and Mike who are going to take this item, but just to give the context, this flowed out, as Hassan said, one of the actions from the last board meeting around some of the concerns that board members expressed rightly about the level of suicide or suicidal attempts within North East Essex. And so we've brought a paper that hopefully people have had a chance to read to set out the context of that, some of the actions that have been taken and the actions that are going to be taken. But Melanie and Mike will take us through the paper.
Welcome, Melanie and Mike. Sorry I didn't introduce you. I didn't realise you're there. You must have been hiding.
I was just Thank you. Thank you, Chair. So I think I'll probably take this, Melanie, if that's okay. So yeah, Mike McHugh is my name. I'm a public health consultant in Essex County Council. I've been working there as an interim since September, covering a lot of the non-COVID public health stuff. And I'm interested particularly in mental health and suicide prevention. And I was asked to have a look at suicide prevention across Essex more generally. Thank you. Timely cup of tea. And to bring a paper to the Health and Wellbeing Board last year. So and I think on the back of that, then we've ended up with some specific recommendations, particularly targeted at some of our districts, including those in North East Essex. So I think the first thing we'd say is that from an Essex perspective, Essex itself as a county is higher than you would predict based on socioeconomic factors. It's a higher suicide rate than the English national average, and has done for about the last, at least the last 5 years. It's about 30% higher than the English average. And then when you dip down into some of the districts, I'll draw your attention, I think, to point 2.3, which I think is quite stark, which is table which ranks suicide rates at district council level. Now there will be, if you had the full ranking list here, you'd have about 270 district councils. But obviously we've got the 10 highest suicide rates, and as you can see, that includes, so Tendring is the second highest in the country, and Colchester is the third highest, and their rates are going on for double the sort of expected rates, or the average rates nationally, which are about 10 per 100,000. The next couple of charts, actually there's an error in the second, in table 3. Table 2 shows the numbers, sort of linking those rates to actual numbers. So in Colchester, we're seeing about, in the last iteration of the ONS findings, we had about 30 suicides per year, and that's steadily gone up, as I said earlier. The table for tendering is actually just showing females, and so the overall total rate, numbers is for tendering is about 20 per year in tendering. So in terms of the data that we're quoting here, Office of National Statistic data, which is very high level and is also not very timely. So the most recent data we have is 2019, and that was finally reported just at the end of last year. So moving down the paper, obviously we know that there are particular risk factors. So on the basis that we haven't had a detailed look at Colchester or indeed tendering, we're kind of drawing conclusions more generally from what is known about risk factors. And clearly it's more prevalent amongst men, probably of a ratio of 3 to 4 to 1, really, men more than women. Although it is increasing in younger people, and especially young women, it's predominantly middle-aged people, particularly middle-aged men. Only 1 in 4 of patients are known to secondary mental health services, although 90% are felt to have a diagnosable mental health problem, but most of those will be seen in primary care. Substance misuse is a clear underlying risk factor in many cases, and then there are other additional sort of socioeconomic factors which are much more common in people who take their lives, such as unemployment, marital breakup, etc. People will be interested to know what has been the impact of COVID on suicide, and what we can say is that although there is clearly a demonstrable impact on mental illness and mental distress increasing in those, so far we haven't been able to demonstrate an actual increase in suicide locally or nationally or indeed internationally since the onset of COVID, which is probably a bit of a surprise to many people. But the table I've included here is based on real-time surveillance from those parts of England which have real-time surveillance, which is about 1/6 of the population, and as yet there's been no clear increase compared to the same time last year. Lots of caveats around that data, particularly given that the latest data quoted from Manchester University in the papers from August. So we've got an ongoing crisis, over the winter, etc. And clearly we're also concerned about emerging PTSD as the crisis resolves, and also the economic impact once furlough ends, etc. And the economic impact is going to be quite significant, and that's a major risk factor in terms of suicide. So in terms of what we can do and what we are doing, essentially we've got 2 main strands of work. So there is a Southend, Essex and Thurrock suicide prevention strategy, which has been going since 2017 and was updated in 2019. There is also, people will be aware of, there is several tranches of NHS England funding coming down now into localities for suicide prevention, and Suffolk and North East Essex was in wave 2 of that, and the funding is now going into its 2nd year. And I've listed all the kind of program of work that underpins that at the end of the paper. But essentially it's concentrated on supporting sort of high-risk groups, tackling self-harm, supporting for primary care, training more generally, quality improvement, and some suicide bereavement as well. One of the important aspects to remember about that wave funding is that it's time limited. It's a 3-year course, and then eventually that sort of work is expected to be carried on sustainably from there. One new development is we've been recently awarded in Suffolk and North East Essex some funding to provide post-vention support. So post-vention support is two main types. So immediate support for people who've been bereaved, and they'll have lots of logistical challenges around funerals and dealing with the coroner, etc. And then obviously the emotional impact of suicide. And it's a lot of the evidence suggests that you do need a very sort of specific bespoke service to provide that support, which we don't actually have across Essex as yet, but we've now got some funding coming down which will provide a service on a pilot basis starting in April, and that will be going out to tender quite soon. So as I mentioned, when I discussed suicide prevention at the Health and Wellbeing Board, the main kind of concerns, I guess, were that we felt that there is a lack of clarity about some of the detail sitting behind suicides, and this relates to not having real-time surveillance, which essentially is where we need to be. Actually, we need to have a system where as soon as the police identify a suspected suicide, that they record a lot of background information, and that gets fed into ourselves and public health. We can have very sort of nuanced look at that data and respond accordingly. As I say, that is evident in about a sixth of the country, and we're making progress behind the scenes working with police colleagues, and hopefully that will roll out in Essex in the next few months. One big gap I mentioned earlier was about suicide bereavement support, and again, that's a big gap across Essex, but at least we've got a pilot coming down into the northeast for the next 12 months. Other issues that presented were that there was a little bit of, I suppose, a lack of focus in terms of the governance of suicide prevention. So these Southend, Essex and Thurrock Suicide Prevention Group hadn't met since 2019. So that's been relaunched. We had a meeting a week or so ago about that. The other thing I highlighted was that it felt to me that there was a real strong case to have a look at suicide prevention at a more local level, given the rates that we have, particularly in 3 of our districts. So we've now set up 3 separate task and finish groups for Harlow, Tendring and Colchester, and Harlow's already met first time. Colchester met today and Tendring tomorrow, and this is about bringing bringing all the sort of partners who have a role to play in the local area to try and work out, try and understand the situation locally and work out strategies to improve the situation. So carrying on from there, I suppose the next steps on this journey.
Mike, sorry to interrupt. I wonder whether we could just pause for some questions, perhaps, and see if anyone's got comments around, if that's okay. Because I think we can take the paper as read, can't
we? Okay.
So Pam D.
Hello, thank you, Hassan. Hello, Mike. This is the second time we've met today, and I'm very pleased to have been invited to the Colchester focused suicide task and finish group this morning. We're short of time, so I won't go into what I thought was a fantastic meeting in detail. We made a lot of progress around suicide, and I do think there's a very strong argument, and there may well be political reasons why we can't do this, and I'll leave that to the politicians. But with regard to Colchester and Tendring, Mike's already said Colchester is the 3rd highest suicide place in the country. Tendring is the 2nd, given the fact that we have such a close connection between Colchester and Tendring, particularly in terms of travel to work. We share, as we know, at the same CCG, the same footprint. I think there is an incredibly strong argument for setting up a Colchester and Tendring suicide prevention group, building on so much of what we already know. And some colleagues will know about the work that we're doing across the Alliance and across One Colchester in relation to inequalities. And so much of this is related, I think, to the work that Mike kicked off this morning. So I would certainly welcome the support of the CCG in creating and driving forward a joint working group. Thank you. And thank you for arranging the meeting. A very, very difficult subject, but incredible progress, I thought. Thank you.
Thank you, Pam. Patrick, can I bring you in?
Yes, thanks, Hassan. Thanks, Mike. There's just some bits for me that I suppose in terms of your report, I'm not clear what the table 2 point, I think you talk, the bottom of 2.3 really tells me, because the numbers just don't seem to match in terms of some of the points. But that's probably something I can pick up with you outside just to understand that a little bit more. But it just feels as from that report on that statement above that the ONS shows for the last 5 years Essex County has a higher rate of suicide than national average. Just doesn't feel we're doing enough. And so I think the question is what can we do more locally? I appreciate Southend, Essex and Thurrock have got the task group, but we've got to do things more locally. And I don't know who came from Adult Social Care to this morning's meeting on Colchester, but it makes sense, doesn't it, from the Alliance perspective, that we think about this as a Tendring and Colchester issue rather than two separate task and finish groups. I don't know whether that was part of the conversation this morning or not, but I'd like to think we could do much more on a local action. What could we really do? It indicates some triggers around GPs. Something like 45% have seen a GP in the last month. So what are the triggers for those cases, and how could we respond to those through the mechanism for GPs, and how do we trigger that? But it still means 55% are not seeing GPs. So what are the triggers that we can do much more about through a task and finish group to help address that? Because this is really worrying in terms of the numbers that we're talking about here. A question about the age profile. I couldn't see that in the report. I don't know whether you have that in terms of the age profile of the suicides, just to understand the types of not only sex of the victims, but actually the age profile. So I just think we could do more, and certainly happy to have conversations outside with you, Mike, about who from Adult Social Care is on those groups. And I can see from Pam that it was the Colchester and Tendring task and finish groups. Thank you.
Can I just respond to that?
Please.
So, can I respond? So my initial sort of recommendation to the Essex Health and Wellbeing Board was to have a joint Tendring and Colchester suicide because of all the reasons people will be aware of. I got a bit of pushback by some of the elected members at that meeting, but I think it doesn't really make sense to have two separate groups. So I would be working to amalgamate those two groups going forward. That'll be my view.
Okay, thanks. Can I just, Pam, do you want to come in on that point?
Yes, I don't think I was clear enough. No, Patrick, it wasn't a joint task and finish group. Colchester was this morning, Tendring is tomorrow. My argument this morning was it should be. And there seems to be a lot of support for that in the chat and more generally. And, you know, the resources we could save and the joint approach, the collaboration with the Health and Wellbeing Board in Tendring and one Colchester in Colchester, which of course incorporates our health and wellbeing responsibilities, I think could be extremely powerful and give us access, as Ed has suggested, straight into the Alliance and all the partners who collaboratively can have an impact on this.
I can't see any reason for that not happening, Pam. So I think it's probably worth understanding the barriers to doing that, if there are any. Jerry.
Yeah, paragraph 2.4, you mentioned that the annual audits of coroner's records for 2019-2020 have not been done, and those give a more detailed understanding of the individual characteristics and risk profiles of people who've died by suicide. Are they still going to be done? It seems if they were, then it might help answer some of the gaps Patrick's identified.
Yeah, so the ordinarily, depending on capacity, etc., some of the public health staff would go into the coroner's office periodically and go through the records one by one, essentially. They are still that is a very labour-intensive piece of work, and it's been very challenging to do during COVID because of all the restrictions, etc. And it also carries with it a kind of a delay, because there's often 6-7 months delay before a case that gets to the coroner's office is declared, concluded as a suicide. So I think in former times it was it was a better option than just looking at ONS data. But we're really moving forward now with real-time surveillance, which I'm hoping will be up and running in the next couple of months or so.
Okay, thank you.
And that will
Max?
enable us to look at them almost week by week.
Okay. Max?
Yeah, thanks, Chair. Yeah, just to sort of remind everybody, actually, it's just over a year now since we lost a GP colleague through taking his own life. So we're also doing quite a lot of work as a GP wellbeing group locally to try and prevent mental health problems in terms of our primary care colleagues.
Thank you, Max, for reminding us.
Can I just add on that? Max has I've had discussions with Max and colleagues. One of the areas we probably do need a bit of support from the CCG is around the primary care training. We've got funding for primary care training through the WAVE funding, and it's just proved very difficult to deliver. I don't know if Melanie wants to come in on that, but it would be helpful maybe to get some CCG support behind that.
Yeah, thanks, Mike. Yeah, just briefly. So we have been collaborating with Mind, M&E Mind on this, who have got somebody set up ready to provide the training to GP practices. They've got a number of dates set up now and have been advertising those dates, promoting those dates, but there's been very little take up from practices. I've recently heard that there's been discussion the next 3 GP shutdowns of the training being delivered then, but I don't think that's been confirmed as yet. And we're just conscious that we're now nearly at the end of year 2 of the Wave 2 transformation funding programme, and that training hasn't really happened. So we're really keen for that to move forward and could just do with some support, really.
So I think I speak for Pam in that I don't think we're a barrier to that support, and I think we'll support in any way we can. And I know we do have monthly educational events, and just as is the way, it's they've been redirected towards one thing or another over the last few months. And so if there's a case that we need to badge one of those for this, I mean, you may know, Melanie, I don't know if you were there, we did dedicate an event on a wider footprint, and that's but the move from that is to try to have more practice based. So there's no reason why we can't support that, encourage that, and perhaps we should look at that outside of this meeting as to whether or not we can make it compulsory, as it were, for practices to do that in one of their shutdown events. That's within our gift, I think. Okay.
Thank you.
Pam, you got your hand up. Was that to support that?
Yeah, I'll take that as an action.
Perfect.
And we'll work with the practices to get as quickly as we can that training rolled out. Just mindful that we're pushing people really, really hard at the moment in primary care, and we should be more aware of the workplace stresses for our workforce, let alone our public as well. So yeah, I think we need to be pushing that out quickly.
Thanks, Pam.
Thank you.
So I'm just going to ask a question which you probably can't answer, Mike, if that's okay. So I've been going to Health and Wellbeing Board for quite some time, and I know that our stats are poor when we look at national average in terms of suicide rates. And I'm also a GP, so I know the medical reasons, clinical reasons, social reasons for why this happens. But why? Why are we second and third in England? I mean, I've come from London. And I know that it's all multifactorial, and I come from London where it's busy, there's more deprivation, people are more crowded, people don't have the green spaces, they don't have the open roads, they don't necessarily have the schools, they don't have the community links. So why are our figures so bad?
So thank you, Chair. That's a really good question, and I am a bit baffled by it myself, and that's why we're digging under things a bit. I mean, why we would have 3 districts which have the highest rates in top 10 so in the country. Generally speaking, suicide does follow socioeconomic status quite faithfully, and on that basis, Essex should be better than the national average, but it's actually worse. So just on that alone, you'd say there's something odd going on there, and same you would say people might understand what tendering, very deprived part of the world, etc., etc. But it's still not the second most deprived district in the country, and certainly Colchester isn't in the top 10. So there's something going on. I haven't as yet been able to find any simple answer to that, but that is a very good question. But that's the reason why we need to be digging into it much more.
Okay. I mean, I think when we set up this task force, it'd be useful to try and understand that, because I completely agree we need to look at the action plan in terms of preventing and what to do, but it's understanding why we need an action plan in the first place is what's going to help us resolve this. Prashant, do you want to come in? Are you on? You put your hand?
I'm on mute. Yeah, thanks a lot for letting me speak, Chair. It is interesting. We are, as you say, Hassan, quite high in our suicide rates, and I welcome the fact that you've got a fund aside for training purposes, because that's the right thing to do. But at the end of the day, training and transformation and everything is very good. A final common pathway for both primary and secondary care is the execution of it. And yes, I agree with it that at the end of the day, we need to look at the risk factors. We need to remind ourselves why people commit suicide. And it's a systemic problem, I would say, as far as my observation as a frontline GP goes, is that I need backup from secondary care if I find somebody at a high risk of suicide. And I find myself the system wanting sometimes that things don't sort of match up. The cup is too far from the lip. So it is not just primary care who is at fault, I would say. We need to sort of build capacity into secondary care, because I have problems trying to access people to then come and section somebody who's at risk of doing this to himself or to somebody else. So when you do the deep dive, when you set up the action task force and the action plans are coming out, please look into all these factors.
Thank you, Prashant. Max, do you want to come in before we get Mike back?
Yeah, I think there's still confusion, I'm afraid, over the suicide awareness training in primary care, and we've had some good discussions locally about how to facilitate it, how to support it in terms of backfill, how to use the shutdowns, but I still think there's a little bit of confusion, a bit of lack of clarity about what actually is our plan in terms of making sure that happens. We've had discussions that in Suffolk, they've been much more successful in rolling it out, but they don't do it as a practice-based thing that people just come. They just have events to which people come to. So it's not a practice-based training, which is kind of where we started with the program here in North East Essex. And actually, logistically, it's really, really difficult to do that, roll it out as practice-based training across the patch, unless it's got a lot of push behind it and support from CCG, and it almost becomes mandatory, if you see what I mean, and that's the only way you're going to, I think, make sure it does happen as a rolling. And it does make sense to have it as a practice-based program, because you need practice teams to transform the way they manage suicide risk rather than individual practitioners, which is where so I personally like that concept, but it just seems to be really, really difficult to make that happen. And the shutdowns, I'm afraid, are not the answer, because they're just too infrequent, and you can't train all the practice. It would take about 5 years to train everybody, through the shutdowns.
Well, shutdowns are every month, Max. Where every month for a afternoon, all practices are closed for an educational event.
How many practices are there?
39 last count.
Yes, that's about 4 years, isn't it? So
no, it's not that. No. So this thing is, maybe we have a conversation outside, because understanding what the level of training is, because actually, if it's delivering a seminar, there's absolutely no reason why we can't do that centrally for all 40 practices in one go on an afternoon. But if it's got to be more individual, then that's a different feature, isn't it?
I don't think you can do it that way.
No, well, like I said, I think that's probably a conversation we're having, and that's the action that's Pam picked up. I do think, though, that we do need to take a little step back and think, well, actually, is it just about practices? Do we need to have a wider audience, and how do we do it bigger? But I don't want to go too big if we've not even managed to achieve the small. Pam, I'm going to leave you for a minute and just bring Pam D in, if that's okay.
Thank you. It's on that very point, Hassan, that you just made about the wider audience. So I absolutely understand and would support the vital role that GPs have in this, and it was highlighted this morning at our meeting. But I think there is a wider audience for this. I'm thinking about some of our wider public sector workers, housing officers, environmental health officers, people who go into people's homes to assess hoarding, fire and rescue officers who go in to do home fire safety checks. You know, we have an observer scheme in Colchester whereby if one of our refuse team see some strange behaviour, for example, refuse piling up or refuse not being taken out in the first place or curtains remaining closed, there is a mechanism that this can be reported, and they are the people who I think can be our first point of contact in seeing something that's not quite right, that might ultimately lead to this situation. So my plea would be for mandatory generic audience training so that we know what to look out for. Thank you.
Agreed, Pam. Thank you. Pam G.
So, Pam, I think they're really salient points, and I think speaking to the mental health trust, that actually our shop workers that are selling ropes, etc., to people, our taxi drivers that quite often deliver people to the site where they do undertake suicide is also a route that we need to be looking at, because there's lots of other people that can be supporting people in this. So we need to think of that 40+% that don't go anywhere near the GP. I just would like to know, having done lots of work in my other points in my career around the projections of mental health and suicide post-economic downturn, what modelling you're doing for the increase in suicides post-COVID yet, whether that's even part of this modelling for the future, because I think we're in this position now, and quite legitimately we could be seeing the position significantly worsen because of COVID, and I think we need to be aware of that and very ambitious in what we're planning, because this is not going to be an easy phase to start getting good processes in and support in place.
Did either of you, Melanie or Mike, want to come back on that point before we?
I think it's a really good point, Pam. I mean, obviously, there have been lessons learned from previous economic downturns and so on. I know it sounds a bit glib, but people have said that recessions hurt, but austerity kills. You know, so it's how we respond to those economic challenges. And I would say more broadly, I mean, I think there's a danger that we oversimplify this. This is a very complex problem. GP training is clearly one aspect of it, and you know, I think you know, a person's suicide risk starts to become computed at the time of conception. So there's a whole, you know, a person's journey to eventually taking their life is a very, very long, complex journey, and there's so many points that we can interface with that. So it's about trying, you know, in my summing of it, I think we need to be certainly addressing the risk factors, and they're clearly economic and many others. But we need also to be putting in place good support systems for people when they are struggling. And so training's part of that, et cetera, et cetera. But it's, you know, I don't think we can oversimplify this problem.
Thank you, Mike. Prashant, you put your hand up again.
Yeah, as an extension to what Pam has just said, it's not all doom and gloom, because in the new world we have got PCNs, and thank you, Pam, for allowing a mental health worker with every PCN. So yes, there is risk assessment, there is training, and all that is very important, but we have access to our own PCN mental health worker. So that's the first port of call. We can sort of access that. So as I said, it's not all doom and gloom, but we have in the past worked in CO3 and CO15, and we might have lessons learned from these aspects when we had a fireman going in, doing the risk assessment, which what Pam Donnelly just alluded to. Basically, I think we have got a lot of work where we can learn these lessons from, and they just build on that and have the easiest pathway created if it can be done. Thank you.
Okay, thanks, Prashant. I think I disagree with you a little bit. I think it is doom and gloom. You know, if we're second and third highest in England at suicide rate, then I think it's time to. Sounds a bit cheesy, but it's time to do something about that. So I know, you know, the ICS, when we started, we had an aspiration, didn't we, to be zero suicide. So I think it's just trying to understand how we get to that, how we realize that ambition. And I think, you know, key to that is understanding the why. You know, why are we in that position? And then we can work out the action plan that goes with it. Because, you know, whether we tackle GPs, okay, that's maybe people have seen a GP, or 45% of people have seen a GP prior to committing suicide. That doesn't necessarily mean there were any clues or pointers at that consultation. You know, there's not necessarily a direct correlation. But as Pam said in the chat, you know, it's taxi drivers, it's your work colleagues, it's your neighbor, you know, it's your postman, it's whatever. It's all the people within the community that have contact with those individuals that might be able to pick it up. So I think it's got to be a bigger and wider piece of work to try and educate everyone. I mean, I have no idea whether any member of the public knows that we have the second or third highest suicide rate in England. I mean, I suspect a small proportion do. But actually, I'm pretty certain most of friends and peers who aren't in the profession wouldn't know that. And it's quite a shocking statistic, isn't it, when you think about it, especially when you start to look at the numbers and think, actually, you know, that's real people per month rather than actually just a number on a table. And that's somebody's brother, somebody's sister, somebody's, you know, father. I think we need to try and have a robust action plan for this, which is wider than that. So I take from this conversation that, you know, we need to look at that education event, but I think we need to think wider about how we can involve other groups, how realistically we can do that. And, you know, maybe that's down to every organization having a compulsory module. So we as GPs have Blue Stream, whatever, you have to do some compulsory training around things like equality and diversity. So, you know, why is suicide prevention not one of those? And why is it that we don't look at larger institutions, organizations that work with over 20 employees or whatever, just as an arbitrary figure, and say, look, actually, as part of your training, you have to have suicide prevention, you know, mental health first aid. You know, we should start to think wider about that. And I think the other action is around this, the task group setup. I do agree it makes sense for it to be a joint task group between Tendring and Colchester, so call it North East Essex. And I'm sorry, but I'm not clear about how we go about putting that in place or how we set that up. But I completely agree. I think that needs to be our direction of travel. Mike, Melanie, did you have anything else you wanted to? Oh, sorry, Pam, have you got a question? Sorry, I didn't see your hand up. Sorry.
No, it was only, again, in relation to your last point. You say you're not sure how we could set that up. Well, there are a number of ways of doing that, obviously, but with the agreement of the Alliance board, which meets at the end of this month, I'd be happy to coordinate with my tendering counterpart, John Fox, who everyone knows, I think most people know, and Mike, in relation to my role on the task and finish group, and at least make a start on this. But others may well have more experience than I have to do that, but I would certainly be willing to do it on behalf of the Alliance. I think it has to be an Alliance-led initiative.
Okay. Richard.
I really don't think it's a big issue. I think we run the tendering one tomorrow. It was sponsored under the auspices of the North East Essex Mental Health Board anyway, which is North East Essex wide. So run the one tomorrow and then bring them together in the next meeting makes eminent sense. I don't think it's any more complicated than that.
Okay, completely agree. Patrick?
Thanks, Hassan. I just the only point might be around the political oversight that's required. So we might just need to think about how we report back to the different councils, maybe back through into the Health and Wellbeing Board, to give them assurance that we are looking at it as a whole, because it makes sense to come together, but actually we are thinking about the boroughs and districts specifically. so that there's some assurance on that basis.
Okay. Councillor Brown?
Would you like me to take this back to John Spence? Because I think if he understands that what you're trying to do, he'll be fully supportive and he will give you the county council's support.
Yep. I think what we need to do is maybe set up that task force first, and then what I'm trying to avoid is duplication of conversations and people having the same conversation in different areas. I think what we can all agree is that this needs to be a priority and needs, everybody needs to be looking at this collectively across every organisation. But what we also need to do is make sure we're all having the same conversation and bringing it all together. And I think for me, that's the key. And we've talked about ICS, talked about CCGs, talked about task force, and we've also talked about health and wellbeing board. So it needs to be high up on the agenda of everywhere, but it just needs to be owned somewhere and actioned somewhere. And that's the bit that I think I'm struggling to describe at the moment, but that's probably the work that perhaps the task force can help us bring together. Mike, Melanie, in which case thank you so much for coming and presenting this topic. It's really important. Oh, hang on, I don't know if I've got a bit of a lag. Ed, you got your hand up, sorry if I missed you.
You call me a lag?
Not publicly.
No, it's not being recorded. I think it would be welcome if we could bring this back to the board just so we keep our focus on this. So it sounds like we've got a good way forward in the Alliance context, but I think it's important the board takes ownership and as I say, we can then represent the work we're doing at the Essex Health and Wellbeing Board.
Definitely, I think that's definitely a way forward. So we've got some people to own those actions, if that's right. So Pam, you've got a couple of actions around the educational event. And Richard, if you could perhaps just report back at next board or around how we can bring the task group together. In which case, thank you, Mike. Thank you, Melanie, for coming to talk to us. Very important. Another comment. Oh, perfect. Okay. So let us move on then to procurement board. Paul.
Yeah, thank you, Chair. I'm not sure I can follow this discussion we've just had, but I'm also aware that we're probably pretty short on time now, so I'll take the paper as read. This is proposal that I think has been discussed on a number of occasions, certainly stretching back some time. This has already been also agreed at subcommittees. So essentially, the paper proposes bringing together of the expertise of procurement across the 3 CCGs together, with a view of making sure we have a review of the procurement program, make sure we use all existing expertise and standardize our approaches, and also save time and provide some transparency to our procurement processes. I think it's really important to note at this point that this doesn't absolve the accountability of each individual CCGs of that procurement process, and the CCG still own that procurement decision. But I think if I may just say a couple of things in terms of the context. I think we're in a bit of a juxtaposition between the pace at which we're moving in partnership working and a legal framework around procurement. As I'm sure we've seen time and time again, we've fallen foul of trying to move really at pace in procurement and being challenged, whether it be legally or to some technical issues. And if I can just remind you that in a long-term plan, there were some clear proposals that would be looking at actually changing the competition laws and rules around patient choice, whilst also thinking about changing the NHS Public Contracting Regulation 2015 Act. So again, I think we are likely to see some changes happening, and we need to be a step ahead of those changes. The final point really to make is that doesn't mean that there won't be any procurement. There will still be a need to consult. There will still be a need to engage. There will still be a need to make sure we get best value for money. But actually the process will change. So it feels quite the right time, really, given EU transition and other issues, that we should sort of enact our long-standing proposal that we should put together a board that works on behalf of the 3 governing bodies to manage and the procurement process across the system. And I'll stop there. Happy to try and answer any questions.
Thank you, Paul. I think it seems a sensible way forward. Does anybody have questions, comments, concerns about the approach or detail? Okay. In which case, we approve. Oh, sorry, Pam.
Yeah, and you'd expect me to say this, Paul. It's just making the linkage with the alliance governance so that we can, and I think, you know, you're clear on that, but so that we can have the right engagement, the right approach, strategy with wider commissioners as well, thinking about integration with health and social care. How do we develop that strategy and keep everybody cited, so when it comes to a committee, actually it's understood what our strategy is in each part of the alliances.
Okay.
Yeah, if I can quickly come back to that, that's absolutely correct, Pam. This is not for a committee to set the strategy and the direction of travel. This is really to support the process, try and speed it up, make sure it's safe.
Thank you. So I won't go back, but I think we're happy to approve. Wait for a second. Fine. Okay.
Thank you.
Thank you, Paul. Amanda, you want to take us through the next bit?
Thank you very much, Chair. So we have 3 current terms of reference which have been slightly updated following a recent review. So for ease of reference, the comments and suggestions are shown for ease of reference, but the 3 terms of reference that we ideally would like to agree as a board this afternoon are the Finance and Performance Committee, the Quality Committee and the Joint Collaborative Committee. So I'm not going to go through each of the terms of reference, Chair. I think the updates are very clearly shown in red for ease, and I commend all 3 to the governing body this afternoon to approve. Thank you, Chair.
Thank you, Amanda. So I might just for, well, actually, I'll just take them en masse if that's okay. So I'll pause for a second if anyone's got comments or concerns about any one of the 3 terms of reference. If not, I'll just come to the individual chairs. So Martin, are you happy with F and P?
Yes, very happy. It's
okay.
Really that we've got Paul on board now at each meeting with that really incisive view of what's happening up to date. Excellent.
Pam, are you happy with quality?
I am, thank you. Yes, Hassan.
Okay. I guess I'll say I'm happy for the collaborative group, because have you got any concerns, Ed? Collaborative, are you happy with it?
No, none at all.
Okay. Perfect. So we will approve all of those. Thank you, Amanda.
Thank you, Chair.
So the next item I think is owned by me, compliments of John. So be under no illusion, John's done all the work for this, but isn't at board. So I'm presenting it, and it's really just to summarise a conversation that we've had in the past around the slight changes in the constitution, all summarised in the paper. So really just presenting to everyone so that it's there, and you've had an opportunity to look at it again. Happy to take questions or comments. Seeing as I've lived this for about 3 years now, it's quite nice to just get it signed off and move away from it. Okay, so we'll take that as ratified, approved. And we're on to the, is that you on the next one, don't you, Amanda?
Yeah, indeed. Thank you very much, Chair. So here we have our current policy on conflicts of interest, gifts, hospitality and sponsorship, which has been in existence for a number of years now and is subject to an annual review. And indeed, that annual review took place at the end of last year. And again, it was looked at by the local counter fraud service as well. There was a conversation and good discussion at the audit committee in December, where the audit committee are recommending that the policy with minor updates is reviewed and updated and agreed by this afternoon. But I will very happily take any questions, Chair. Thank you.
Any questions? Max.
Just occurs to me, with regards to, obviously we will declare our interests and everything. Is there any analysis done of those declarations of an interest in terms of how they, you know, are they sort of in line with our policy, and you know, are they reported in the right way, etc., etc. Do we get any? Does anybody do any work on that?
Indeed, thank you, Max, for that. Yes, we do. And our governance advisor and officer, Joe, collates all of the interests as they come through, which we do update every 6 months, and we do publish it on our website. So they are all looked at individually.
And they'd sort of look to see whether they fit the policy were correct, were done correctly. And
definitely, Max, absolutely, with rigour.
Thank you.
Thank you, Amanda. And we should, every time we have a board meeting, obviously we try and match them against the agenda, which I try to do. But obviously, as you can imagine, it's sometimes subtle, so it's useful to have the backup of the governance team doing that. So if there's no other questions, we're happy to take that, to adopt that. Thank you, Amanda. So Simon's had to leave because he had a meeting, Simon from Comms. But I'm not aware there has been any questions. I know there was a question that came to us by mistake, was directed towards Suffolk. I don't know whether Richard or Ed, has that been addressed elsewhere?
That's been addressed. Thank you, Hassan.
Perfect. Okay. In which case, then we'll move straight on to our operational report. So we've got remuneration and HR committee report. Amanda?
Thank you very much, Chair. So this is the first time we have produced such a report to the governing body, but we felt it would be in keeping with other similar committees. So as you can see from the paper, REMCOM last met in October, and that was a committee in common. And that is now going to be the preferred kind of stance going forward. We were due to meet in fact next week, but that has been postponed due to current COVID requirements. But going back to the October report, you can see that a lot of the items that we did discuss are really standard agenda items where we review each meeting our management running costs. We also have a report on our workforce KPIs. And last October, we signed off our race equality standard report, which I think was well received. And then we had an update on our conflicts of interest training. And whilst it was 48% in October, further communication and work has been ongoing to improve our compliance. So there will be a further update at the next REMCOM. And we have a standard agenda item on updating members on the ICS. So that pretty much is a standard suite of information, which does change, obviously, depending on what there may well be to inform the Workforce Committee. But I'll leave it there, Chair, and happy to take any questions.
Thank you, Amanda. Any questions? No, in which case we note the report. Thank you, Amanda.
Thank you.
Jerry, if you don't mind, I'm just going to bump you for a second because I know Mark's got to leave at 3:30. So if we could just do the Alliance Committee next. Pam, unless you've stepped out of the room, not knowing.
I'm happy to say, Hassan, that we had to postpone the last meeting due to operational focus on COVID, and we have taken any updates we have electronically. But I'd go over to Pam to update about the rest of the Alliance work.
Thank you, Mark.
Sorry, thank you. Yeah, so the paper, what I asked for this board was the fact that we would give you a summary of our work and the strategy and the governance all in one sort of easy read place so that you could be reminded of exactly how the Alliance is working. And I think it's important with the topics that we've seen to date in this meeting around things like the suicide prevention, how those things map in to the work that we're doing and around place particularly. So I'm happy to take absolutely any questions on this paper, but I hope it's a very logical view of the work that we're doing. And we just simply took the opportunity of not having a specific meeting and content to report on to give you this update around strategy group, our operational groups, and how we manage the Alliance work around the long-term plan. So I think it's important to note that whilst the committee hasn't met, the tactical group meets daily at the moment to manage the pressure in the system, and weekly as a very whole system approach so that we can keep everybody updated. The other meetings are obviously not able to be supported at the moment, But we are desperately trying to keep as much of the alliance work going. So some people that are more protected from COVID work are looking at the finance arrangements around delegated budgets, etc. So there still is work going on, but I wanted to make sure that you'd got an update as to where we were at the moment.
Thanks, Pam. I think, to be fair, every item we talk about brings in the alliance. So actually through that approach, I think we talk about the alliance quite a lot rather than necessarily have to direct it towards a report, don't we?
Yeah. We
Max.
have had to slow up the neighbourhoods work, though, for obvious reasons because of COVID. And I think we were successful in completing the population health studies approach with NHS England. And that formed the basis of starting some really positive work in Colchester, and then following very quickly in Clacton and South Tendring. So when we come to the items around suicide prevention, etc., that's part of the population health study approach, and the teams will be designed to support where the biggest level of need is for those sorts of things. So I think that's the anchor that we've got constantly in what work is the alliance doing, not just to bring us together in bureaucratic terms, but actually to do something different that reflects the place that people live and the connections between GPs, health, and our elected representatives from local districts and boroughs, which is an aim that we have post-COVID, is to link those on a place-based approach.
Yeah. Thanks, Pam. Max, you got a question?
So that was my question about neighbourhood teams, so I think Pam answered it.
Okay, all right, perfect. In which case, if there's no other questions or comments, thanks, Pam, for bringing us a report, and thank you, Mark, for fronting it. And so, sorry to have bumped you, Jerry. Are we able to come back to you?
Yeah, thanks, Hassan. I think you've already mentioned, or we have already mentioned, the main thing that we discussed at the audit committee, which was whistleblowing policy. And I think you already know as well about the new external auditors being appointed, which was BDO, which was the other main thing. Apart from that, happy to take any questions.
Thank you, Jerry. Any questions for Jerry? All right. Perfect. Okay. Thank you, Mark, and thank you, Jerry. Then, so let's try to remember where we were now. Right, integrated performance report. Thanks, Paul.
Thank you, Chair. If I may say a few words, and I'm sure that Martin will want to comment. I've gone through FNP in terms of scrutiny, in terms of performance. If I may say just a few things. If you look at the report, I think you'd be forgiven to say that the report itself looks like a pretty good news story in many ways. And I'd like to point towards performance rate cancer in particular. You'll notice that on month 8, 62 days was 84.9%. Again, that is even better performance than pre-COVID in many ways. So there's a lot of evidence that RTT is improving, diagnostic is improving, even some of the waiting lists have improved, which is testament to the system working that we've had with private sector support, and if you remember, phase 3 productivity improvement, sort of post wave 1 COVID. Sadly, though, in December, we saw numbers of COVID patients increasing significantly within our hospitals, reaching some pretty dizzy heights, which essentially caused a postponement of routine elective activity, essentially from mid to late December onwards. Now, the things I can say about that is we moved really, really quickly by enacting essentially the national surge contract with private sector support, which essentially means we moved from 75% utilization of our private sector to full 100% utilization. And that's been partly designed to try and protect cancer work and protect what we call P1 and P2 activity, i.e. life-threatening surgery, to make sure that the activity continues. I'm pleased to report, and I was already alluded by Ed earlier on, that the numbers of COVID patients appear to be gradually reducing, which is great news. So what I would say is that the system remains focused on performance improvement and recovery, but actually has been hugely challenged with regard to COVID prevalence within our hospital sites. The other thing I would say is key to actually trying to maintain emergency services, which have been maintained, has been the work that the Alliance has been done. We've talked about the Alliance already, inter-partnership working, daily tactical meetings that Pam was already mentioned, which has meant that our front door stayed open for the most needy patients and has carried on. The other impact of COVID obviously has been on workforce, and at FNP we had a bit of a discussion about that in terms of the impact that would have. And again, it's just a recognition that all parties are working under significant pressures to maintain the services that we have. So broadly, a tale of two halves. The report itself demonstrates some improvement, but actually we have to recognize that COVID incident levels will mean that we are likely to see a deterioration in performance as we move forward to January onward, if not sooner. And I'll stop there and happy to hand over to Martin if you want to add anything to what I've just said.
Thanks, Martin.
Yeah, I think, well, Paul's covered the vast majority of items we discussed last Friday, but I think obviously the biggest challenge is when we come out of COVID is catching up with all the elective work that's been put on hold, and it's going to be an awful lot of challenge going forward there. And I think, you know, it's often said that any organisation's most important asset are its people. And one thing that came out of Friday for me was the intense pressure that the workforce has been subjected to over the last year, and tiredness, burnout is going to be a major problem going forward, which is going to have to be brought in and considered as we go forward, because a lot of people are going to need a bit of a rest as they come out of COVID, because they presenting such a monumental effort in getting us through this national pandemic. So I think for me, what came across most of all is workforce, and when we come out of this pandemic, how we go forward and make sure that, you know, we take everybody with us and we give them all a rest. But so I think that's my main comment on all of this, but the rest Paul has already covered.
Thank you, Martin. Thank you, Paul. Has anybody got any questions? So essentially, we're picturing a fragile position. Is that what we're saying, effectively?
Yeah, I think I would say that. I think that the system is very fragile anyway. Whenever we look where there's problems in the amount of people we're treating, inevitably it comes down to people. And this goes back to what I was saying earlier. There always seems to be, when we drill down into any area where performance is not quite meeting the standards we'd expect, it's usually because it's a person, you know, maybe a consultant has gone sick, or there just doesn't seem to be the redundancy within the manning levels that we can afford to lose any people without having quite a serious effect on performance. So I think that people going forward, that's why it's my major concern, is really as we go forward to make sure we haven't burnt everybody out.
Okay. Thanks, Martin. I think it's important. I think that's the important thing for me, isn't it? It's the burnout, because actually staff are working above and beyond at the moment everywhere across all different organisations, and it's just, you know, we're pinning our hopes on this vaccine, and I hope that it takes us to where we want to be in terms of getting out of this. But it's just keeping on top of it, because it's, you know, whilst this is all going on, you know, GPs need to still be doing their job, and there's still surgery and outpatient clinics that need to be carrying on. Otherwise, actually, the backlog that would occur were we not to do that is just unimaginable. So it's I think for me that's the key thing, is just making sure that we've got a grip on doing what we need to, but making sure we've got another just sight on the longer game, to make sure that we've not just firefighting, getting to a point where in 6 months we're just going to be in an impossible position. And I understand that's very, very difficult to model, and we're no different to anywhere else in the country, but that's the important thing for me. So are you reassured about that, Paul? Martin?
Yeah, the only comment I would make, Chair, is I think we do understand the problem. So whilst we've continually reported a growing size in waiting lists, that's not necessarily going to be the issue. The issue is that our waiting lists are going out of shape. So actually you have a lot of people waiting for 52 weeks now, and it's about the quality and safety of those patients as we move forward, or that we already have in the system. So essentially we're going to have to do two things as we move forward. Make sure we work as efficiently as we can. Workforce aptitude comes into that discussion. Make sure that we have a solution to manage the patient we already have. think about some additional capacity, but also think long-term about transformation of services in terms of what else can we do to manage future demand, to allow us a chance to catch up. So I think we have some clear thoughts about how we might do it, but it will be an absolute challenge.
Okay.
Can I also say, Hassan, that I think, on the brighter side, we still are treating cancer patients, people presenting with urgent problems and diagnostics. So, that is the sort of the more positive side of it.
Yeah.
People who are very ill are still being treated.
Oh, completely. And I think the point I was just making is that it's important for us to do that, but it's the backlog of the non-cancer, non-urgent that actually, if you allow it to build up too much, then you're suddenly getting to a point where you've got a whole raft of burnt out staff and a burnt out system, let's say, trying to catch up. So it's just making sure, if we're starting to drip a little bit in to try to just control the flow, knowing that at some point, God willing, we'll be in a better position.
And just finally, and that's why I made the point that we moved really, really quickly with private sector, because essentially we move a whole load of cancer services into Nuffield and Oaks. So actually we're protecting the most vulnerable patient in terms of elective lists. So it's about the lessons learned from wave one, where almost everything seemed to stop. Well, not quite, because we carried on, to be fair. But actually it's making sure we don't repeat some of the mistakes being done regionally and nationally.
Okay. Max, sorry.
Sorry to go back to vaccines, but is there no way we could get, certainly at the hospital trust at least? I mean, I don't know whether anybody's heard today, but we've had a very sad death in one of our community nurses. She's actually tragic, and these people are really up the front line. ACE nurses, the hospital nurses and doctors. We can't just ensure that they have their second vaccine as soon as possible, and make a sort of decision locally that that's what we're going to do. It's not that many people, and I'm sure the general public would understand. Sorry to raise that again.
No, I'm not sure who's going to be able to tackle that then, Max. I don't think it's out of any individual will to not give the second dose. The guidance from Public Health England is around the system benefits of waiting the 12 weeks.
And we've heard about, I think this morning we heard about the daughter of one of the managers at the hospital, who's a nurse, or I think a nurse at the hospital, who's had their vaccine 3 weeks ago and has just gone ill, quite ill with COVID, and is off work, obviously.
Yeah, but I'm not sure you can correlate that with not receiving a second dose. To be fair, that also, so we're told by Public Health England. Lisa.
Well, you've really said it, Hassan. I was only going to say that unfortunately we haven't been allowed to go ahead with second doses for health and social care staff, and there are thousands of them, so they're not a small number across Suffolk and North East Essex. So there are 10,000 people employed in Esneft alone.
And of course, let's not forget, it's not just NHS staff, is it? It's anyone who's had one jab. But I think that's the guidance that we've been given, Max, and that's the guidance that we have to follow.
I understand.
Thank you for raising it. And I'm obviously sorry for the loss of yet another person who's worked with us. That's just tragic. Any questions about the report, though? Okay, let's move us on to primary care commissioning report then. It's a bit cheerier, is it, Pam?
Well, yeah, it is a little. So I think it's important to note the change of name for the committee. So this was the GP Commissioning Committee previously, and on the guidance of NHS England, it's now called the Primary Care Commissioning Committee. So I'll take the paper as read, but essentially we've covered the fact that we continue to have the support for primary care in our system through estates, through working with NHS England, and the asks that are broader than vaccinating, but within the report obviously is a highlight around the vaccination activities that we're undertaking. And since the paper was written, we have been able to expand to the hub and spoke model. So it's not just the 3 centres that we are delivering vaccine from. We're delivering some more vaccine, the drug through GP practices that are assured and able to deliver vaccine in large enough volumes. So we continue to work with the CQC where there are patient concerns around access, etc. And we have a number of initiatives that we're working on with NHS England around mental health to ensure both mental health and LD patients are supported through this difficult time. Since this paper was written, we have had a national position on income generating activities that's around QOF that NHS England have reported to us. And also we've taken a local position that we will step down any of the reporting for some of the initiatives, some of the planning that we had expected to be done by the end of the year. Genuinely, the efforts that primary care are putting into both vaccinating and admission avoidance are the most critical things, and managing the general health of the population. It's very difficult to sit in a position and ask them to do quite in-depth business cases for monies that we're returning to them through PMS, GMS reversions, which is a contracting change that happened historically, those sorts of things. So we have lessened the burden on our practices to ensure that that they can focus on the most important things at the moment. We have vaccinated most of our primary care staff, just a few left where they've either had COVID themselves or been unable to access practice support, the hospital, but we're working on that as the hospital remains our hub for vaccinating staff at the moment. So I think that's whilst I accept it's not the second vaccine, I think we quickly managed to support the primary care community on that front. So I'm happy to take any questions.
Thank you, Pam. Got any questions? No? Okay, in which case, thank you. Let's move on to quality. Lisa, don't forget you got to pick up the action as well.
Yes, thank you, Hassan. So we had a much slimmed down quality committee, really, if I'm honest, because as Pam said at the beginning, the majority of my team now are supporting the vaccination programme. So we had a number of people that weren't available to us, but there were a number of reports shared. We had an in-depth discussion around 2 quality visits to EPUT and some of the recommendations that came out of those visits. We obviously looked at the Ockenden report, and we had an update on SEND with the joint commissioning work stream that Richard's leading on. Spent quite a bit of time looking at the IPC. We continue with weekly infection management team meetings with ESNEFT, and the IPC lead has done a quality assurance visit to Colchester Hospital site, which was positive. I have to say there were a few things. No one's ever perfect, but it was a positive visit. The 3 risks that were highlighted, I think one is our oldest risk that has been going on for quite a while, which is around the staffing at Clacton Community Hospital. They continue to have the 75% vacancy rate. There has been some further mitigation around beds implemented to reduce the risk, and ACE continues to manage it through use of agency. We also spent some time reviewing the E-East and the quality improvement plan that they have since they've been put into special measures. But probably the biggest risk to services at the moment, as Martin was saying, is around the workforce and the acuity of patients that they have, the additional beds in critical care, the additional non-invasive ventilation beds in the acute trusts, and the strain that's putting on the workforce with significant vacancies. So that was probably our discussion. Now, around the action, although we had the HSMR reports and the shimmy data, we didn't, I have to absolutely confess up that I hadn't passed that action from board to quality committee, but actually I do want to do a deep look into mortality figures at Colchester Hospital at the next quality committee, because there are some concerns around deaths and the number of deaths that have happened. So I'm going to, if that's okay, I'll make sure that that's on the agenda for quality committee next month, and we'll report back.
Thanks, Lisa. I'll close the action for you to do that, if that's okay. Questions? Pam, can I ask for your comments? Anything to add? Pam D.
Sorry, yes, I am trying to get.
Oh,
it's just taking a little bit longer, so I have nothing to add. Thank you.
Thanks. So no questions. Okay, you got off lightly then, I think, Lisa. Thank you. So area prescribing committee report. Pam. G.
Yeah, it's a very short report. It's just to update on the most recent activities. I'm happy to take any questions, but it's of technical nature. If you might have to answer them for me if it's about the particular drug, Hassan.
Well, people better not ask questions then. Have we got any questions about the APC? No? Okay.
Thank you.
Lucky you and lucky me. Right, let's move on to the COVID Resource Approval Committee. I have to say it in full. Jane, are you there? I haven't heard from you all meeting. Oh.
I am. I'm here. So, so the report just sets out the approvals that have been made by the committee that works across all three CCGs. Looks at extraordinary approvals for mainly associated with COVID. So you will see that in the appendix there basically is a table setting out all the approvals from when we last reported to the last board meeting until the 13th of January. There has been one meeting since then, but that'll be picked up in next time's report. We shared a number of papers with the Finance and Performance Committee. This was one of them, so it has had separate review.
Thanks, Jane. So we didn't get a formal F&P part of the report, did we? So Martin, have you got anything you wanted to add?
No, only that I suppose from a finance point of view, there's just 2 months to go now to the end of the financial year, and we're predicting coming in on budget. So that's quite astonishing, really, I think, considering everything that's happened in the last year. So congratulations to Jane and her team that have managed that. There's still 2 months to go, and there always might be some hidden quirk. At the moment, cost pressures around continuing healthcare and community costs, but we're hoping to come in on budget, and no reason why we shouldn't do that. So that's from the financial point. And as far as the crack goes, the whole purpose of it is to allow urgent spending to be done in a very agile way. And we've looked over, there wasn't a finance and performance person, we had a Q&A on Friday, but no reason to believe there's any problems with the spending we've seen. Obviously some big ticket items there, particularly around beds, but we've no reason to believe there's any issues.
Thanks, Martin. Do you know, I'm always desperately trying to avoid calling it crack, and then I realise it's listed as crack in the appendix anyway, so I might as well just save myself the effort of not calling it crack. Right, has anybody else got questions or
just said
comments?
Crack 4 times, Hassan.
I did, didn't I? Yes. My sincerest apologies to anybody out there listening or watching this recording. Perfect. If you've got no questions, comments, and we can move on. Thank you, Martin, and thank you, Jane, for bringing us in budget for the end of the year, hopefully, subject to the next 2 months. So, Amanda, can you take us through the strategic risk report?
Absolutely. Thank you very much, Chair. So here we have our most up-to-date red risk report, where we're showing 9 current risks. Each of the risks, as you can see, have been updated by the relevant director lead for January. In addition to the update, we continue to discuss risk at various committees, including our operational executive committee, as well as our risk forum that works across both Suffolk and North East Essex, and has departmental representation whereby we review the entire risk as well as the red risks which are presented here. I don't have anything particular that I would like to highlight to governing body bar what's provided in the report, but very happy to take any questions, and I'm sure director colleagues would be happy to answer any specific questions pertaining to their risk as well. Thank you, Chair.
Perfect. Thanks, Amanda. So has anybody got questions or concerns in this instance around anything on the strategic risk report or what's highlighted in the report? I'll just pause for a second. If not, then thank you, Amanda. We note the report. Okay, let's move ourselves on then to Health and Wellbeing Board. So unfortunately I wasn't able to attend last time. So Councillor Brown, were you there?
I attended part of it. That's why I haven't written you a report. There was an interesting paper on mental health, and Health Watch Essex had sent in their report, and Nick Hume highlighted that he thinks that bereavement support is something that we've got to really focus on, and you've already brought that up in the meeting today. Hidden needs and staffing are the things that they were really homing in on at the Health and Wellbeing Board, and by staff they meant NHS staff. I think it's something that Mark was there as well, so I'm sure he'll be able to fill you in, but I literally dropped in and out of the meeting, and it left me with not enough to bring back to you. I'm really sorry.
Okay. Well, grateful for your feedback. Unfortunately, I wasn't able to make it myself because it's just well, it was a diary clash, I think, which I didn't realise. So we'll note that. Thank you. And that moves us on to AOB. So have we got any other business? I've not been made aware of any beforehand. So in which case I'll call the meeting, or call a close to the meeting. I'm not exactly sure how we stop recording though if Simon's not here. Does anybody know